Now, one of the real, what we all see in our daily life again, it's Fitbits and Apple Watches and wearable technology and Omrons and A&D machines. Everybody's got wearable technology. I don't. This is non-digital anyway, but most people seem to have wearable technology. And so when we were planning the meeting, I thought, let's have two talks from real leaders in this field about where we're going, all this avalanche of data that's coming to us about heart rhythm abnormalities, about blood pressure and heart rate variability, everything. And so it's a great pleasure to welcome Professor Lis Neubeck from here at Edinburgh Napier University to the first of these talks, which is on community and individual detection of atrial fibrillation. Is this the tip of the iceberg? Lis, thank you very much.
So I was given this talk, I thought I would highlight the tsunami or the iceberg of undetected atrial fibrillation that we might be facing, or are we? So just a bit way of background. We know that there are a huge number of people living globally with atrial fibrillation. And atrial fibrillation increases the risk of stroke around 5-fold. But it's estimated that as many as 1/3 of people with AF are undiagnosed. And the first time that they present is when they arrive at hospital having had a large stroke, because strokes with atrial fibrillation are typically more debilitating or fatal. And the recovery period is significantly more tortuous. It costs in the first year around 3 times as much to treat somebody with an AF-related stroke as it does to treat somebody with a stroke of other origin. Around 30% of ischemic strokes are caused by atrial fibrillation. So what we wanted to do was think about how it was we could prevent people coming in and their first presentation being with a large stroke. So the ESC guidelines were updated in 2020, and they gave this recommendation: a standard 12-lead ECG, which we've always used or used for a very long time for the detection of atrial fibrillation, or a single lead tracing of 30 seconds or more, showing heart rhythm with no discernible P waves, irregular RR intervals, as diagnostic of clinical AF. Now, this is new in the guidelines because previously we've always said that confirmation of diagnosis of atrial fibrillation needs to be with a 12-lead ECG. And I'm going to persuade you, hopefully, to embrace this rather than the NICE guidelines, which still state we need a 12-lead ECG for confirmation of diagnosis. So over the last 10 or 12 years or so, there have been an explosion of new devices that we could potentially use to detect atrial fibrillation. And I'm going to talk about a little bit about some of them and some of our experience of using these to detect atrial fibrillation in the community. And these are the devices that are identified. This is also from the ESC guidelines. So we've got patient-initiated or medical-initiated blood pressure monitors, which detect atrial fibrillation as the cuff is deflating. They measure the RR interval and give us an estimation of whether there might be a problem. This is not diagnostic according to the guidelines, but it can be a good option for screening if you're already screening for hypertension. So that would be my first point, is why not use one of these devices that can also pick up AF? Most of us are already using some kind of sphygmomanometer. We have photoplethysmography, which is using the light from the phone, very similar to the way we detect oxygen saturation. Again, we get a pleth wave, which, whether it's irregular or not, can give us an indication, but not diagnostic. Pulse palpation, let's not forget about it, it's still a very valid method, but it's quite a difficult skill to acquire. And most studies show that very few people are very good at pulse palpation. And you need to be able to record the pulse for at least a minute in order to effectively detect atrial fibrillation. Most of us don't do that. Patients tend to talk throughout, so it shouldn't be thrown away, but I wouldn't put it as my first line recommendation. So I'm not going to talk too much about patient-initiated screening with smartwatches, because I know that we're going to talk more about this tsunami of data that people are collecting on wearables, but it is something we need to be mindful of. And there are high quality single lead ECGs available on these wearable devices. They could be considered diagnostic. The Apple Watch has got an integrated one, some of the Fitbits do, and these are reasonable quality and have been approved for medical use. We have single lead ECG devices, and I'm going to talk mostly about those because these are now in the guidelines as a recommended way we can detect atrial fibrillation. We've also got a variety of different smartwatches. Of course, we can look for longer with Holter monitors, wearable belts. The one that's pictured here is the Cardio belt, which is incredibly uncomfortable for women, so not necessarily my first pick. We can also have continuous ECG patches, and we'll talk a little bit more about how often should we look. And of course, implantable cardiac monitors, which is not going to be the main thrust, but definitely a way we can also detect atrial fibrillation. So I'm going to talk first of all about the cardiac heart monitor, which is a single lead iPhone-based ECG. It was one of the first of these types of devices. And since its inception back in around 2010, it's developed an on-device validated algorithm for detection of atrial fibrillation. And the recordings are automatically transmitted to a secure server, and the health professional can then review these ECGs on a server. When it was first created, it worked by activating the device's speaker. It was only iPhones when it first came out, and in fact only had license for vet medicine. It's easier to get licenses to treat animals than to treat humans. And now the later versions of these also have 6 leads and work by activating Bluetooth, which makes them better at reducing some of the problems that we have encountered in terms of using these devices. The problem with the Cardia is you also need a separate device, but we can talk about that as we go on. So I'm just going to see if we can get the video to play. Yes, thank you. So this is an example of an alive core ECG. It's only going to show you recording very briefly, but they do record for 30 seconds. It's pretty reasonable trace. We can enter the patient data. It then can either be printed and overviewed on the screen. We can send a PDF, we can import it to the patient's records. It can be emailed to you if you want to give one of these devices to your patients or recommend them to your patients. So they're pretty accurate in terms of their ability to detect atrial fibrillation. So just to show you again the rhythm strips that you get from the Cardia, you should see that it's pretty easy from these 2 rhythm strips side by side to be convinced of which is atrial fibrillation and which is sinus rhythm. And the value of this is that because atrial fibrillation is such a classical, easy recognizable rhythm, we can confidently diagnose it just from lead 1, which is what most of the single lead ECGs record. So when we first decided we wanted to do something about preventing stroke, we decided to do a pharmacy-based study, and this was conducted in Sydney in Australia. And we looked at the feasibility of whether we could do this in community pharmacies. The rationale was that the majority of people visit their pharmacies every month, and it might be a way that we could access population who perhaps don't attend for healthcare, but they do go in to buy tissues or they go in for their over-the-counter medications. And we wanted to figure out if this was cost effective. So we did a cross-sectional study and we trained 10 pharmacies in Sydney, and we made all customers aged 65 and over eligible to have screening, and I'll talk a little bit about why that is as we go on. We looked at their medical history, we did their pulse palpation, and we did the IECG or single lead ECG, and all suspected AF was referred to a cardiologist. We proved the previously stated point that people are not very good at pulse palpation. It wasn't a successful finding, but the study was really good at identifying previously undetected AF. So we had proportion with newly identified AF and the incremental cost effectiveness ratio per quality adjusted life year gain and per stroke avoided. They screened 1,000 patients and the mean age was 76. So we found newly identified atrial fibrillation, that's people who'd never had AF before, was found in 1.5% of the people that we screened. Sorry, I'll just highlight here that the particular finding that was really interesting is that in all of those patients, and it should say CHA2DS2-VASc above where it says 100 there, all of the patients who we identified who previously didn't have a known diagnosis of atrial fibrillation were eligible for oral anticoagulant treatment according to the CHA2DS2-VASc scale. So this was a high-risk population that we identified. The other interesting finding of this study was how many patients didn't know that they had atrial fibrillation. So we had 23 patients who told us that they'd never had a problem with their heart, they didn't have any funny rhythms, they didn't have AF, and of those 23, 18 of them were receiving oral anticoagulants. So there's a big knowledge gap here with people living with atrial fibrillation. And when we looked at the cost effectiveness per quality adjusted life gain, this is modelled cost effectiveness data, was just under 6,000 Australian dollars and around 30,000 Australian dollars per stroke avoided. And the NICE guidelines suggest to us that this is well within the fundable range. So per stroke avoided to detect and treat atrial fibrillation, it's within the fundable range. Now, I'm just going to talk about our assumptions. We made assumptions in this based on what's known in the literature about adherence, and we've already talked a bit about adherence at the moment. So if we assume 55% adherence to the oral anticoagulants, then we get that quality adjusted life year ICER of just under 6,000 Australian dollars. But if we could get adherence up, the cost effectiveness becomes better. So it's worth us thinking about the whole sequence of screening, because if we screen but we don't do anything about it, we're not really doing any benefit to the patient, and we need to think about medication adherence. The other thing to think is the more you look, the more you'll find. So we only looked at a single time point, but there are a number of studies that have looked over longer periods of time. And of course, I've talked about single lead ECGs, photoplethysmography, blood pressure monitors, continuous monitoring, implantable loop recorders. So if you look for a period of 2 weeks, you'll find around 5% of people who previously had undetected atrial fibrillation. We've also done a systematic review of all of the screening studies. We found 24 screening studies that had looked at a single time point in terms of detection of atrial fibrillation. And we wrote to the authors and asked them if they would give us their data. And we persuaded 19 authors to give us their primary data. And we had 140,000 patients in this systematic review that we looked at whether or not this was worth doing. The number needed to diagnose to find one treatable case, number needed to screen to find one treatable case of atrial fibrillation is around 87. So we don't need to look that hard. On the other hand, I have had people say to me, but I screened 100 patients and I only found 1 or 2 people in AF. Well, that's what we expect, and that's a good outcome. So just thinking about how we've transformed our services over the last little while. Well, Telecheck AF is probably one of the most successful studies that was disseminated largely on social media. And this was created by Dominic Linz in Maastricht in partnership with Jeroen Hendricks. And what they did was they started using photoplethysmography to monitor patients in the community. By disseminating the information about the study over Twitter, they spread it out to 40 clinical centres across Europe. And we had one participating site in Scotland. We had over 54,000 ECG screens obtained, and we're still analysing the data, but I think one of the most interesting things for me is how pleased the patients were to find their support through this PPG monitoring. This was in people with known atrial fibrillation, so this was a slightly different approach. But thinking about the future and where we might take this forward, we're currently doing a study we call SHOPS AF, and we've embedded a single lead ECG in supermarket trolley handles in Liverpool. And we've been recruiting patients as they come in the door. And this has been a really interesting study because people have been really excited about it. And we've had to overcome some challenges like the motion of a supermarket trolley is not always as slick as you might hope. And we used a particular device called the My Diagnostic, which again is a single lead ECG, but it doesn't communicate with Bluetooth. So every time so it's got a flashing light, and when it picks up atrial fibrillation, it flashes red. So every time it picked up red, we had to unscrew the handles and take the device out. So it was a proof of concept, and we screened over 2,000 people in the space of around 8 weeks, which was about half the time we thought it would take us to do this. So as a recruitment strategy, it was great. But there are some kinks to iron out that we hope to take forward in the next study. But there's other technology coming down the road. This is a study that's come out of MIT, and it's using motion and color amplification to detect atrial fibrillation. So every time your heart beats, your skin changes color, obviously at a rate that we can't actually detect with the naked eye, but we can use motion and color sensors to pick up that color change and to tell us if there's an irregular pattern. And this has huge implications of how we could embed this technology to pick up atrial fibrillation without having to approach people necessarily, but of course implications about data security, privacy, and so on. So we need to think these things through carefully, but the future is happening. There's a study that's just been published that shows that you can pick up atrial fibrillation in people who speak on the telephone. So we don't even need to see them, we can pick them up through this new technology. Again, doesn't fulfill the ESC criteria for diagnosis, but it's certainly a good way of screening people, particularly when we can't see them in person, and we've got to think about sending devices out. So the questions I think you need to ask if you're going to use one of these devices to detect atrial fibrillation is, what is the sensitivity and specificity to detect atrial fibrillation? And there are published data on this. We also want to know, has it got appropriate regulatory approvals as a medical device, particularly if we're using a single lead ECG? We really need to know that this has met appropriate standards and is being monitored. What's the cost of the device, but also what's the cost of using something to connect the device? So I mentioned that the AliveCore required to have a connected device in order to use it. So the AliveCore itself, for a single lead, costs around £99. For a 6-lead ECG, which uses slightly different technology and probably gives a better trace, it's about £150. You can use it as a single lead, or you can use it as a 6-lead by placing your thumbs on one side and the third sense, which is on the back, goes on a knee or an ankle. And that gives you all of the limb leads. So what's going to be the cost? Well, you've got to provide a device as well, or get the patient to download an app onto their own phone. Many patients, although they have mobile technology, we're finding really don't have new technology. So we need to think, do we also need to provide a device, or should we provide something else? So the other thing, of course, in this, following on from COP26, is it disposable or renewable? Are we just creating lots and lots of plastic waste? And that's obviously something that we would be really concerned about. Will it work in my particular area? So what is the local setting, and how am I going to make this work with all of the technology I already have available? If you need something that requires Bluetooth and also requires to go up to a wireless setting, then we definitely need to be thinking about what's the available resources. In the original AliveCore studies, we found that very thick walls, like in a building like this, would interfere with the signal on the phone and therefore would cause problems in terms of our detection. And I think probably most importantly is what will happen when the test is done. Is if we don't think about that connected bit of the piece, we're not actually doing anyone any favours by finding AF if we don't effectively manage it. So we need to have this as part of an integrated pathway. And I think the important thing then is to recognise that if you're going to have it as part of an integrated pathway. It should be built around the patients and not the technology, because as I've highlighted, the technology moves on so rapidly. So if we build into a technology that's available currently, it's actually already outdated. There's something newer coming along. We need to be very agile in terms of moving on with the tech, but making the systems work for our patients. So just to talk a little bit very briefly about the obstacles and opportunities across Europe, we're currently taking part in a Horizon 2020 study looking at what it is might work for AF screening across Europe. And we've conducted 26 semi-structured interviews with healthcare professionals, policymakers across Europe. And we've really been looking at what are the national approaches to AF screening, looking at what people think about other disease screening programs, and we had some AF screening scenarios to ask people questions on. And this is really our findings of this particular study, is that we know that opportunistic single time point screening, as I've described, is happening in patchy places. Opportunistic prolonged screening is less well utilised, although it's beginning to be used in places like Sweden. Systematic single time point ECG, this is where we actually get a group of patients and we proactively call them in rather than waiting for them to present. There is very limited evidence for systematic versus opportunistic. So at the moment, the guidelines say opportunistic. When somebody comes in, bare minimum feel their pulse, but ideally also check their heart rate either on one of the approved devices or ideally a single lead ECG. And of course, we can see the beginning of patient-led screening, which is problematic because the people who are most likely to initiate patient-led screening are those who are lower risk of having a stroke. So why don't we look for AF in younger people and people under 65? Because when you're younger, you're more likely to have a tachy response. Your AV conduction rate is likely to be faster, so you're going to have a tachyarrhythmia. Whereas in the single time point studies in over 75s, we know that the mean heart rate was around 78 beats per minute. So it's not a tachyarrhythmia, it's sometimes a bradyarrhythmia. And those people are less likely to be symptomatic. So they won't present with symptoms, and their pulse rate is not an indicator. So we do need to look a bit harder in that age group. Of course, the CHADS-VASc is very much emphasises the importance of age in determination, so it becomes less cost effective to look in a younger population. So guidelines recommend screening over age of 65, and there's pretty good evidence for sticking to that. So when we talk about patient-led, it's people like me who are likely to have the devices, and we are seeing a beginning of people presenting with quite a lot of not necessarily worrying arrhythmias, just some abnormalities. So just vaguely to finish, this is just some feasibility ideas. We need to think about the challenges of the inclusivity. How do we include people who don't walk through our door? We still need to convince our national screening committees that this is worthwhile, and there are prospective studies that will, we hope, show that screening for AF actually prevents stroke. We strongly believe it does, but we haven't got that evidence yet. And we know that some people do need to have additional training for ECG interpretation, but I think we can be fairly confident in the algorithms that are there. But it could potentially cause an increased workload for primary care, and we have to think about that and how that happens and how we work together between primary and secondary care to ensure that loop. And really, we've just been looking at all of the screening studies to pick out the bits and pieces of screening that we think are important. We think that screening strategies should be healthcare and population context specific, so it's not going to be a one-size-fits-all approach. The screening mechanisms that we use need to be convenient, inclusive, accessible, time efficient, and they need to be highly accurate to detect AF. The support mechanisms, we need to encourage healthcare professionals to engage more with AF screening and align with appropriate follow-up pathways for the individuals. And we need to think about the screening yield and cost effectiveness. because it's dependent on the type of population being screened, the type, intensity of duration of screening and wider support mechanisms. And so I'll leave it there and over to you for any questions.
Liz, thank you very much. So we do have a minute or two for questions about atrial fibrillation, because maybe short, not everybody here knows this, but the Public Health Scotland and the Scottish Government are setting out the priorities for cardiovascular disease over the next few years, one of which is hypertension, the second of which is atrial fibrillation, because I'm sure you know that already. And so this isn't just vague talk for a meeting, you know, on a Thursday afternoon. This is happening nationally very quickly. Now, Morven Dunn, who's a long time member of Sharp, you know, the fabulous Morven used to work at Glasgow Royal, but until we lost it to government. Morven promised me she was going to listen in this afternoon. We had a meeting on Tuesday about blood pressure, and I'm sure that Morven Dunn is pushing us towards a meeting of atrial fibrillation for Scotland. So, Liz, can you tell us what are we as a nation going to do about AF quite soon? Because I know this is under discussion at government level.
Yeah. Okay. So I think we're still we're still in a little bit of equipoise, because we have this problem with ESC saying one thing and the prevention task force. But I'm convinced that we should look for atrial fibrillation and we should use the technologies that are available to us to do so. We've got a really good study led by Neil Grubb that shows that this works in Scotland, in the Scottish setting, with primary care. And it's sad in a way to see that we haven't moved faster with it when we know that the evidence that we can do this, and it isn't particularly inconvenient and it's very cost effective, is there.
I actually did not just want to ask my questions all day, which I would do. But it's a question from the audience. In fact, no, it's coming in from outside. Population prevalence of atrial fibrillation is low in younger people. Yeah, fair enough. But what about the anxiety associated with false positives? False positives of diagnosis of AF in this wearable technology? Given if there's more anxiety than there is picked up of AF, are we just going to make a whole lot of young, anxious people even more anxious with wearable technology?
Yeah, I guess that's a real problem, potential problem with the wearables, and this is why I would advocate for a program that is in consultation with healthcare professionals, so that we're managing this effectively, because we know that atrial fibrillation is fairly rare under the age of 65 and is likely to be symptomatic. So those people are probably going to come to your attention. The concern then is where people pick up something that's probably not AF. And the false positives are relatively small. And there is, of course, a risk with false positives, but it's probably a fairly minor concern. There's not really anything in itself in a single lead ECG that's going to cause you any harm. It's the patients that we've had who we've picked up AF with have been incredibly grateful. The patients who have not had AF thought it was nice, weren't bothered, didn't mind doing it. So we've never had anybody complain to us that we've picked something up. They tend to be really pleased. And I'm not aware of us having had a single false positive in about 12 years of screening AF patients.
I tell you what that tells us. Professor Neubeck is brilliant with patients, doesn't that? Thank you. Right, one more question. We're a few minutes late now. Any more questions? One more question at the back. Say your name, say where you're from, because they can't see behind the mask. Tell us who you are.
Technology. Hi, I'm Ryan Mareski, one of the research fellows in Edinburgh. I just worry with some of this wearable technology that what all we'll do is end up identifying the people who would already identify, because they are going to go to their GPs, they're going to already have their Apple Watch, and it's your 56-year-old or your 65-year-old man from Glasgow Royal who, even if he's got an Apple Watch, isn't going to check himself for AF. And how do you think we can go over that disparity?
Yeah, it's a massive problem. How do we reach people who are not currently identifying them for our services? We are just about to start a study in the Glasgow Dental Hospital, because we think people are more likely to go to the dentist than they are to go to a doctor, because if you've got tooth pain, you want to be there. And there's evidence from the dental ARIC study that periodontal disease, which we knew caused leads to an increased risk of stroke. The mediating factor is probably atrial fibrillation. We've never prospectively looked for atrial fibrillation in that population, but the dental ARIC study suggests that that's the case. So what we think is this might be somewhere else. We might reach people, but it's always a problem. How do we get it's a problem in every study I do. How do we get the people who we most think need our support to participate in our studies and in our interventions?
Yeah, it's great. Well, we do the same in blood pressure. We did this before for main measurement. We did it in supermarkets, football grounds. We have a project going in dentistry as well, which I'll tell you about maybe next year. Professor Neubeck, thank you very much. That was terrific. Thank you.